To our first event for National Public Health Week. I'm Donna Arnett. I am the Dean here of the UK College of Public Health. And we have put together a tremendous panel of advisors from our board and Dr. Omar, and I'll introduce them in a moment. The structure for today, we're going to end around 1 o'clock. The governor has a flight at 2, so he has to depart at 12:45. So he's not mad at us or anything. He's going to do something very important tomorrow in Washington. And so the structure is I'm going to ask each of them a question, and they're going to speak for about 5 minutes. And then we're going to open it up to the audience for questions. We also have some questions that were submitted by our faculty as well. But I would love to hear from you in the audience. So let's begin. I'm going to introduce our panelist. Dr. Artis Hoven is faculty here at UK, and she's on our board of external advisors. She's past president of the American Medical Association and current chair of the World Medical Association Board of Directors. We have Dr. Omar. He's the chief of adolescent medicine here at UK, and he is an expert in mental health issues in adolescents. We have Governor Beshear, who's also on our board of advisors. The governor has been a tireless advocate for healthcare. As you know, he launched Medicaid in the state of Kentucky and has played an important role, including teaching a health policy course for the college. And finally, we have Sheila Schuster, who is with the Kentucky, I want to get your title correct, Kentucky Mental Health Coalition. She also serves on our board and has been a tireless advocate for the area of public health and mental health in the state of Kentucky. So since all epidemics, like opioid use, substance use disorder, we as epidemiologists always start with the epidemiology of that event. So I'm going to ask Artis to describe the epidemic of substance use disorder in Kentucky and the associated challenges from a medical perspective that results from IV drug use.
Well, thank you, and thank you for asking me to join you today. I have a disclaimer. I am not a public health person by training, but as an infectious disease specialist, I like pus and bugs and that kind of stuff. So I do have an interest in prevention and have become, in the last 5 to 8 years, a totally committed person to making prevention a reality in so many parts of medicine and in healthcare. This is a pretty big topic to cover, but I'm going to go through it. We have people in this room who know these numbers in and out, and I would stand corrected if any of them would throw things at me and tell me to shut up because I didn't know what I was talking about. But let me give you sort of the 30,000-foot view of what this issue of substance use disorder looks like in Kentucky. Kentucky ranks 5th right now in the nation for overdose deaths. That's based on 2017 data. In 2017, we had 1,566 deaths, and each year those numbers continue to increase. We know that in our country, 130 Americans die every day because of overdose deaths. But, interestingly, in 2015, the Kentucky providers, people like me, wrote 97 opioid prescriptions per 100 people. That's a lot of people taking a lot of pills for a lot of pain and something which I will talk about later is absolute suffering that they're talking about. And, if you go back historically, this just didn't happen 5 years ago or 10 years ago in Kentucky. We're talking about really 3 waves of activity around opioid use disorder. We didn't used to call it then, but we now have put that name to it. There are 3 waves of activity. One was the prescribing of opioids in the late 1990s. By 2010, a lot of the overdoses we were seeing in the country were now due to heroin because we had started to cut back on the number of prescriptions being written within the state of Kentucky. And then the third wave in 2013 when the synthetic opioids began to hit the streets and such drugs like fentanyl and carfentanil became the drugs of choice for injecting drug use. And in 2017 in Kentucky, fentanyl was the cause of death in over 50% of the cases. This is synthetic junk. It's awful. It's ugly. It's nasty. We also know that residents across Appalachia, and particularly Central Appalachia, Eastern and Southern Kentucky, are 55% more likely to die from a drug overdose than people in the rest of the country. In Leslie County, the south of Hazard, north of Harlan, I think, the overdose rate is 5 times the national average. 5 times the national average. And why is that? And we'll get into that more in a bit, but we talk about lower levels of educational achievement, high rates of people on disability, but we need to talk about that more and why that happens. And in so many of these places we talk about diseases of despair, suffering versus real pain. And I don't want you to forget that concept because I think it is very, very important. I would also be remiss if I didn't talk about something called neonatal abstinence syndrome, the painful withdrawal symptoms that newborns have when they are born to mothers who are addicted to opioids. We have seen in our state rates have skyrocketed about 23-fold. There is a very proactive work going on right now about this, but that's one more piece of this horrible puzzle. Let me talk a little briefly about something called the Cdc Vulnerability Study, which was done in 2015, resulting from what happened in Austin, Indiana, just a little bit across the river from Louisville, Kentucky. In that situation, an outbreak of HIV was documented directly associated with injecting drug use individuals. And that actually occurred simultaneously with about a 90% infection rate with hepatitis C, again due to intravenous drug use. Out of that study that the CDC did, 220 counties in the United States were considered vulnerable, and many of you probably already know that Kentucky has 54 of those vulnerable counties. And what makes those counties vulnerable? Well, the list is extensive, and the data they used: overdose deaths, unemployment rates, income levels, sales of opioids in those particular counties, access to appropriate health care, just to name a few. DPH, the Department for Public Health, when we saw that study, knew we absolutely had to do something and make it happen fairly quickly. And let me move on then to talk a bit about some of the infectious disease complications that result from injecting drug use and illicit drug use. Now, I like this kind of stuff, and I hope I don't offend anybody but with the terminology that I use. But when I try to talk to patients or talk to groups around complications that can occur by illicit drug use or injecting drug use, I tend to get a bit dramatic. And you know, we used to think of these infections as being inner city problems, urban, inner city, but you know, now it is not. And in fact, our 54 vulnerable counties are where this is occurring right now. Hepatitis C virus, you've heard a lot about that, is the most common bloodborne infection in the United States. And about 85% of those individuals who are currently infected do not know they are infected with hepatitis C. It's the leading cause of liver failure, cirrhosis, and liver transplants. Its primary risk factor, IV drug use. Among people who inject drugs, 30 to 70% are infected with hepatitis C. And in Kentucky, we have seen more than a 200% increase in the number of hep C infections. About 40% of these folks will not clear the infection on their own. They will go on to develop end-stage liver disease. HIV. 10% of cases are due to injecting drug use. We now have the ability in the state to test for HIV at local health departments along with hepatitis C. And this now will raise the whole spectrum of why we need syringe service programs, syringe exchange programs. Fact, only 50% of those individuals who are HIV negative and are injecting drugs are using syringe service programs. Only 50% of them. In the year 2018, we had 352 new cases of HIV diagnosed in the state of Kentucky. Northern Kentucky. I'm going to talk about two specific outbreaks that are directly related to injecting drug use and illicit drug use. The first one is in Northern Kentucky. Using surveillance data, paying strict attention to numbers as they became across our desks, we began to see the number increasing such that now in Northern Kentucky, they have a rate of new cases, 75 new cases, considerably over, and this is ongoing right now as we speak, 75 new cases. 40% of those are co-infected with hepatitis C. What happened was the Center for Disease Control sent a team from CDC called EpiAid to Northern Kentucky, and they began a series of studies and evaluations, tracking patients, learning about them, where they were living, what they were doing, how they were getting their drugs, and learned a great deal about what needed to be done in that part of the country. All of these cases in Northern Kentucky, 100% of them are all injecting drug users. Now, the problem you've got in Northern Kentucky is that you have to cross something called the Ohio Ocean to get to the city of Cincinnati. But what you see are these folks bouncing back and forth between Hamilton County and Northern Kentucky, Covington, Florence, that part of the country. This is ongoing. And how are we going to manage this directly related to substance use disorder, directly related to injecting drug use? And we've also had something recently in the state, actually declared in November, I think, of 2017, is a hepatitis A outbreak. Now, in the old days, we used to think about hepatitis A as, you only got it when you traveled to Europe or a third world country, or perhaps if you adopted a child from one of these areas. It wasn't something you really needed to worry about. And as a consequence, not too many people in the United States have been immunized against hepatitis A virus. But what happened in Louisville was an outbreak which started in the city of Louisville. And subsequently, the data on that has shown now that we have over 5,000 cases. No, we've got 4,300 cases of hepatitis A in the state of Kentucky. It's spread, interestingly, along the interstate routes. Think about that for a minute. And we have had 52 deaths. These deaths did not occur in normal walking around people. These deaths occurred in individuals who had multiple comorbidities, pre-existing liver disease, cirrhosis, alcoholism, you name it. 71% of those infected, 71% of those infected, their risk factor was illicit drug use. Illicit drug use. That epidemic peaked in October and finally now is coming under control. This is just a smattering of what goes on with infectious disease complications, and I would be delighted to tell you more if you wanted to hear about it. Thank you.
Thank you, Ardis. So, Dr. Omar, this is a pretty solemn and grim prospect for our state. So, from a treatment and prevention perspective, what advice would you offer?
Thank you. Just a small correction, I'm no longer chief of adolescent medicine, I'm just a professor in the Department of Pediatrics. My approach always to anything has been, you cannot deal with a problem if you don't understand it. And the biggest problem when we deal with substance abuse is, first we have to understand that once you have an adult who is addicted, treatment is, I wouldn't say effective in any way. The failure rate is high, the relapse rate is high. So if we wait until somebody's already addicted, we're too late. And we have to focus more on preventing people from becoming addicted. So to understand that, we have to look at what makes people addicted. What is the most predictive thing or factor in addiction? And the most reliable predictor of somebody becoming addicted is the age of initiation. So the younger you are when you try alcohol or smoking or substances, then you are more likely to be addicted. One study actually looked at smoking, and what they found is if a teenager smokes 2 cigarettes fully, they have an 80% chance of becoming addicted. Just 2 cigarettes. So if we wait until our kids try something once, the next time they try it, they are already in trouble. And if we wait until our teenagers become addicted, then we have a group of addicted adults. So how do we prevent our teens, our young people from becoming addictive? Because that's the most effective strategy. If we prevent people from trying in the first place when they are young, then we won't have adults who are already addicted. And if you look at the best study, in my view, that's ever done, it's called the Adolescent Health Study that started in 1984 and still continuing. If anybody's interested, you can find it on the CDC or World Health Organization website. Just type Adolescent Health Study. And that looked at kids starting from 6th grade across the globe in 5 different continents, 37 different countries. A total of 154,000 people were enrolled in it. And basically, the main findings is if we provide a support system for young people, meaning having an adult that they can talk to, a safe environment they can interact with, and give them something useful to do, that will be preventive not just against substance abuse, but against suicide, against early sexual activity, school failure. All poor outcomes would be prevented if we do that. And that's, I think, where we are failing our young people here. We are not providing adequate support system. So in part because a lot of kids don't have two parents, and if they have parents, the parents are doing something that the kids are emulating because they see what their dad or mom is doing and they will follow. And also, this is not in a vacuum. You know, just working on substance abuse, just working on suicide, just working on teen pregnancy doesn't work. It's all connected together. If you are drunk or high, you're more likely to have sex, you're more likely to kill someone, you're more likely to kill yourself. So the approach has to be a comprehensive approach to prevention. And it starts, if we really want it to work, we have to start with the families, educating the families, talking to the families, being honest with them. We need to involve the peers themselves. And basically one of the kids that I work with, I've been working with teens for many, many years, basically has a motto is, I'd rather have a mad friend than a dead friend. Meaning, if I see something, I'm going to tell or say, even if my friend becomes, mad at me for that. So involving the peers themselves of helping each other. Involving the schools by being honest again in the schools, how we talk to kids about drug use or any other issues. Making sure that our teachers and school counselors and everybody in the schools observes things, notices things, not being afraid of saying something, because right now everybody's afraid to say this person is doing this or that person or talking to that person. We lost our ability to communicate. If somebody's mad at me, instead of coming to me and say, you did something wrong, they go behind my back and complain. And that doesn't solve a problem. To solve a problem, you address it head on. And then once we get the peers, the family, the schools, then we get the community as a whole. And that would force our politicians also to listen and address those issues. So if we put all those things together, then we have a chance. But on top of all this, we also need to address our healthcare system and how it works. Because the reality is the most common factor contributing, one of the most common factors contributing to our kids becoming addicted is our doctors, us, those who provide care. I've been fighting with emergency rooms and urgent treatment centers forever about when you see a 12-year-old or a 13-year-old with a little bit of pain, don't make your first approach prescribing opioid. Unfortunately, that never resonated. Every teen I saw who went to an urgent treatment center or an emergency room with a headache, a backache, a shoulder ache, a small sprain, they always get codeine prescribed. And again, those are young kids. Their brain is not fully developed. And if you start them on this, 5 days here and 5 days there, they become addicted very easily. So all those factors have to come together: the healthcare system, the family, the peers, the schools, and then that carries to the community as a whole. Thank you.
Thank you, Dr. Omar. So Governor Beshear, during your time in office, you launched Medicaid, and I'm sure that that's had a dramatic effect on the availability of treatment. Do you want to describe that for us?
Well, first of all, after yesterday, I got up this morning and the sun did come up. So I'm at least happy about that. And there's always next year. You know, Kentucky is such a great place in so many ways. And I know that if you're a Kentuckian, you're very proud of where you come from. You're very proud of the different things that Kentucky stands for. But one of the things that none of us can be proud of is the status of the health of our people. You've heard the statistics that Dr. Hoven put out, and there's a lot more statistics. You know, you name any chronic disease or condition known to man, and Kentucky is right at the bottom of virtually every one of them in terms of how bad it is in Kentucky. So that's not something to be proud of. Now, what do you do about it on the state level? Very little, because you don't have the resources to attack these kinds of things just from the state level. Maybe a Massachusetts or a New York has the kind of public funds it takes, but really to make a huge difference in the health of our people is almost impossible for a state to do by itself. So when I became governor, you know, I knew those statistics. I wanted to do what I could, and we did things like we expanded the number of kids in the CHIP program, and we, you know, those kind of things we could do. But was that a monumental change? No. And then, my gosh, along came the ACA. You know, all at once in 2010, Congress actually did something. Not very often that happens anymore, but they actually did something. And all at once, the ACA landed in my lap. And what was I going to do with it? Well, my political advisor said, don't do anything with it. After all, President Obama has about a 30% approval rating in Kentucky, and it would be suicide for you to do anything with that. Well, I didn't like that answer, mainly because, you know, for the first time, we actually had a tool we could grab hold of and hopefully make a big difference in the health of Kentuckians. And so we set out very quietly, as you all recall, right after it passed, lawsuits were filed, it got in the court system, and it was, I think it was 2012 before the Supreme Court held the act constitutional. But during that time, from 2010 to 2012, we very quietly took every single dollar that the federal government was offering in planning money, and we planned. We planned to have our own exchange, and we planned to expand Medicaid. The decision to make, to have our own exchange was a pretty easy one, because all the providers, even the Chamber of Commerce, of all things, everybody thought we ought to do it ourselves because we could design a better system than just have a cookie-cutter type of system that the federal government was going to have. So we went about doing that, and then I had to decide, are you going to expand Medicaid up to 138% of the federal poverty level? Well, that was a tougher decision, not because I didn't know it was the right thing to do, because that's the way I felt. Wasn't any question that it was the right thing to do. But the question was, can we afford to do it? You know, all of the critics said it's going to bankrupt the state. Oh my gosh, you know, we'll all go under. And I mean, that's a legitimate question, and it needed to be answered. So I went out and got PricewaterhouseCoopers, a little international actuarial firm that some of you may have heard of. And I brought them in and I said, look, I'm thinking about doing this, and I want you to take a look at Kentucky, take a look at our people, take a look at our current Medicaid program, and I want you to come back and give me some projections of what it will do to Kentucky or for Kentucky if I do this. And they took about 6 months and came back in and sat down and looked me in the eye and said, Governor, you can't afford not to do this. If you do this, in the next few years, you're going to have 17,000 new jobs in the state. You're going to infuse about $15 billion of new money into your economy. It will help your budget. There's no reason not to do this. And so with that, I had both the moral argument of providing health care for our people and the economic argument of not only can we afford to do this, it's going to be beneficial for us in the long run to do this from an economic standpoint. And so away we went. You know, I still remember, I think it was October 1 of 2013 or 14. I can't remember when we finally implemented it. It was the first day you could. And that night at midnight, you know, we basically crossed our fingers, said a prayer, and threw the switch. And it worked. Our system worked. And the federal government's didn't. Y'all recall it crashed on the first day. Well, all at once we became heroes just because ours worked. I mean, I loved it, of course, but, and, you know, we ended up being the model for the nation in implementing the Affordable Care Act and expanding Medicaid. But the real numbers are something that you ought to be proud of. We had about 640,000 Kentuckians with no access to health care. About 20%, over 20% of our population. In 18 months, that dropped to 7.5%. So what that told me was there was a real pent-up demand from Kentuckians for accessible, affordable health care. And boy, when it was put in front of them, they grabbed it and they ran with it. And so it became highly successful. At the same time that we were doing this, the opioid crisis sort of reared its head again. And as Dr. Hoven said before, it's happened in stages in different places. And of course, government's always behind the curve. But in 2012, the pill crisis, the opioid pill crisis, was sort of a political issue that finally hit everybody in the face. And so we were able to pass legislation at that time to run the pill clinics out of Kentucky, to require all prescribers to participate in the electronic monitoring system so that when someone came in and said, I've got pain, I need some pills, they could plug your name and social security number in and, oh, you were around the corner yesterday to another doctor getting the same prescription you're asking me for. And so that cut down on a lot of the doctor shopping. We put some money into treatment and prevention. We didn't have a lot. But we really started making that effort. And I think we saw a dramatic drop in the prescription drug part of this. But many of you are too young to know the game whack-a-mole. But those that do know that when you hit down on this, something else pops up over here. Well, and again, as Dr. Hoven said, heroin and fentanyl. You know, when people couldn't get their pills, they went looking for the next thing they could find, and that was on the street. And so that really blew up into a big epidemic proportions. And so in 2015, we passed legislation that put Narcan in the hands of all the first responders. We passed a Good Samaritan law that would allow someone who's sitting with you and y'all are both shooting up and one guy overdoses, the other one can call 911 and not get prosecuted. You know, before, people just get up and run, and that person would die that OD'd. And so it's an encouragement to get people to try to take care of the folks they're with. One of the most important things I think we did, and the amazing thing, it was amazing that we got it done, was we passed legislation that allows communities to have needle exchanges. I mean, when my public health people came to me and said, this needs to be in there, and I looked at them and I said, well, I know it needs to be in there, but that's the last thing this legislature will ever do is pass that. Well, the HIV crisis in Indiana that she talked about just a minute ago was the key to us getting that passed, because then Governor Pence, you all may recall that name, now Vice President, then Governor Pence was totally against needle exchanges. But that outbreak and that epidemic in that Indiana community finally pushed him over the edge, and he allowed needle exchange to help combat that. So I went to our guys and said, hey, you know, if Governor Pence can do it in Indiana, surely we can do it in Kentucky. And so we got it passed. So, you know, we made a lot of great strides, but it's a drop in the bucket to what this problem is, and particularly in the drug area. Thank goodness, and a lot of people, when they argue about the ACA, they argue about access and all of this, which is extremely important, but they forget about the guarantees in that law that have nothing to do with spending money. I mean, the guarantees, like, you know, insurance companies can't discriminate against you because of pre-existing conditions. They can't discriminate and make women pay more than men for the same coverage. And those 10 essential benefits that are required in every insurance policy sold in America and required in all the Medicaid programs, one of them is mental health coverage and substance abuse treatment. Never before had we been able to get that into insurance policies, and now every one of them are required to be in there. Now, is it the be-all and end-all? No. You still have to have the facilities. You got to have people trained, and we don't have enough facilities for that. And as Dr. Omar said, you know, the success rate for treatment is not great. I think we've got an obligation there. I mean, we've got so many people addicted, we can't sit by and just let them fall through the cracks. I mean, you can help people, and some of them will recover. I would agree with him that prevention is the ultimate long-term answer to this. You got to get them before they ever get on this stuff. But that coverage in the Affordable Care Act is going to make a big difference, I think, across the country, if we can keep it in the law. And I think we will. All this talk about doing away with the Affordable Care Act, I think you'll see a revolution of sorts now that people are enjoying access to health care. And if they come and say, well, 20 million of you aren't going to get it anymore, I don't think so. I don't think politically that will happen. So we've had an interesting experience in Kentucky.
Thank you, Governor. Sheila, you have been a tireless advocate for mental health in Kentucky, and I know you're so passionate. You probably noticed we have a lot of students in the audience, so help inspire them. What can we do in Kentucky to address this epidemic?
Can I just say one thing before she starts? This is the inspiration, folks. She's been over in Frankfurt, holding our feet to the fire for more years than I can tell you. 1978.
I started when I was 6. So.
Yeah. Well, I was in the legislature in 1974 on, so she was there. And you talk about an inspiration. You ought to emulate this person.
Thank you so much. I'm delighted to be here. Some of you have heard me say, if I weren't so old, I would have gone back and gotten at least a master's in public health, because I really think that's where the action is. So I applaud you all for being students and faculty here. I want to add to Governor Beshear's story just a little bit to give you a context piece, and that is that up until the Medicaid expansion, our Medicaid services here in Kentucky did not include substance use disorder treatment. Let me say that again. Medicaid, traditional Medicaid in Kentucky, only covered substance use disorder treatment if you were pregnant and up to 6 weeks postpartum, or if you were a youth. So we didn't have it. And one of the things I was not successful at was trying to get the state to put that coverage in before we did the Medicaid expansion. And when Governor Beshear did the Medicaid expansion with the 10 essential health benefits, he went back then to traditional Medicaid, which he was not required to do, and say, oh, we need to do this. We need to have substance use disorder treatment. So it gives you a little sense of where Kentucky has been contextually. The other piece I will tell you is that, and many of you may not know this, is that Kentucky was the very first state to implement President John F. Kennedy's Community Mental Health Act, signed in 1963 and finally implemented in Kentucky in 1966 by putting into statute the statewide array of community mental health centers that we call CMHCs. We were the very first state in the nation to implement that statewide, so that we had, at that time, 15, now 14 community mental health centers in their regions. And they were obligated by statute to provide mental health treatment, substance use disorder treatment, supports and services for people with intellectual and developmental disabilities. So I would like to think that we were still number one. Unfortunately, the funding for those community mental health centers, like the Department for Public Health, as Dr. Hoven knows, has been decreased. I meant to look before I came over this morning. We're either ranked 46th or 47th nationally in per capita spending on mental health. So we've got the structure out there, and those CMHCs are barely holding on. So for years, they couldn't treat substance use disorders directly. They had co-occurring disorders walking in the door. They could treat you for your anxiety, but if you were drinking to your anxiety, technically they couldn't treat you for your alcoholism. And Kentucky has a long, long history, unfortunately, of addiction. If we look at our tobacco and we look at our bourbon, one of the things that gets lost, actually, in what we talk about now is substance use disorder is the fact that we're still not dealing appropriately with alcohol addiction. And we know that kids very often try that as a first thing. We worry about kids who start smoking and vaping now and using Juul and get started down that road toward marijuana use and other drug use. So that's some of the context. We also know, and again, Dr. Hoven did a great job of talking about, we're at the epicenter of that opioid epidemic. West Virginia, Ohio, Kentucky vied 1, 2, 3 there for a long time about who had the worst opioid problem. We were on the I-95 corridor coming north from the pill mills in Florida. And where did it hit? It hit at one of our most vulnerable areas, that Appalachian region of Kentucky. And what do we have there? We have the very hotbed for growing addiction. We have super high poverty rates. We have super low academic achievement. We have super high unemployment. We have despair or hopelessness, no future, and so people will do anything they can to address or to assuage that feeling of despair and hopelessness. So we have all of that going on. The legislature did act with House Bill 1 in 2012 and snuffed out the pill mills and cut back dramatically on the prescribing, and they're still trying to do that. But let me give you, I spend lots of my time in Frankfurt. In fact, I was telling the student who so kindly walked me over that my car automatically goes east on 64 from Louisville to Frankfurt. And sometimes I'm in Shelbyville before I remember I'm supposed to be going to Bowling Green or Covington, and I'm like, oh, it just goes that way. It's on automatic pilot. So let me tell you what I hear in Frankfurt. I hear legislators who say, we shouldn't be doing needle exchange. In fact, there was a bill that did not pass this session to limit it to 1 needle per 1 needle. Yeah. And what are they thinking? Or are they thinking? What they're saying is, we don't want to give people the means to do an illegal activity. And we know they're going to shoot up, which is illegal, so we're not going to give them those means. We're not going to be enablers. They picked up on, unfortunately, some of the 12-step language even. We don't like medication-assisted treatment because we're substituting one addiction for another. We're substituting one substance for another. There was a very important bill that Representative Kim Moser from Northern Kentucky, who's so aware of this, has led the drug task force up there, had a bill to try to curtail what they call prior authorizations from the insurers and the MCOs, so it would ease the ability of the prescriber to prescribe Suboxone or whatever the drug of choice was. Flew through the House, did not pass in the Senate because the legislators don't want to substitute one substance for another. The debate is still going on about whether we should continue to criminalize them. There's a huge debate still. We don't want to look easy on crime. So we're going to incarcerate people, and are we going to be sure that there's any treatment that's going on in the jails and prisons? Probably not. We don't think that people should be revived with Narcan multiple times. How do you like that one? It's like 3 strikes and you're out, except it's 2 strikes with Narcan and you're really out.
You're really out.
They should learn their lesson. That's a pretty deadly lesson. Now, these are not things that legislators are necessarily saying on the floor of the House or Senate when they're on KET, but this is what I hear in the floors. And let's not think long-term. Let's not think prevention. To Dr. Omar's point, we have more children in Kentucky than in any other state whose parents are incarcerated. More children whose parents are incarcerated. We have 9,000 kids, last count, and probably growing again, who are in the custody of the state. We have countless children who are being raised by their grandparents because one or both parents are either dead from an overdose or are incapable of doing that parenting. And you know, years ago when we were trying to address child abuse, we used to talk about breaking the cycle of child abuse because it was multi-generational. We felt like kids who were abused very often turned around and were abusers, and we wanted to break that cycle. Well, what do we think of these kids that have been raised in families or not in families where, as Dr. Omar pointed out, addiction is really the name of the game, where you don't deal with your problems, you don't communicate your problems, but you do anything to ease that pain. And Dr. Hoven, again, is right. You know, when we go back to the 90s and the pain, patient's pain was made that 5th vital sign, and people got so sensitive to it. I mean, I remember having a hysterectomy in 1994, and they said on 1 to 10 scale, what's your pain? And I said 32. And the nurse said, no, you don't understand. And I said, yes, you don't understand. You know, I remember it very well. So what did we do? We did everything we could so that that pain rating would come down. And the easiest thing and the most effective thing we thought, and we were told that it wasn't addictive, OxyContin, right, was to use opioids. So I applaud Dr. Chang, who's over here trying to look at post-surgery patients and trying to change expectations. Think about patient education. If you think you're going to have a significant surgical event and not have some pain, that's a problem because you're going to do anything you can to not have any pain. And we are responsive to that kind of thing. And so we're prescribing when we shouldn't be prescribing, and we're not doing the kinds of things that we need to be doing. The other factor that I will mention, because it's such an issue both with mental illness and substance use disorder, is stigma. And stigma is alive and well. Just because we all are here talking about it doesn't mean that families are talking about it. Doesn't mean that school counselors are talking about it nearly enough. Doesn't mean that churches and youth groups and boys and girls clubs and big brothers and big sisters are not talking about it enough. You know, we had a tragic event last year ago, February, where 2 students in Marshall County were gunned down by a fellow student and killed. And there was an immediate reaction from the General Assembly because the General Assembly wants to be fixers. They want to fix this problem. And so they did an interesting thing. They did House Bill 604, which if you look on the LRC website for the 2018 session, was a beautifully designed bill. it said, you know what, we need to create trauma-informed schools across this Commonwealth. We need to bring in and integrate into our school community licensed mental health professionals, psychiatrists, psychologists, social workers, alcohol and drug counselors, marriage and family therapists. We need to make them available both to students and to parents and to the school staff. And the bill flew out of the House and got over to the Senate, and they didn't pass it over there. Because what did they want to do? They wanted to arm teachers as a response. So the legislature had a working group, 6 months long, of a school safety working group. And I made sure, because I'm really good behind the scenes, that they created kind of an advisory committee and that we had a school psychologist on there because I wanted them to talk about mental health. And fortunately, they did not go any further with arming teachers. They did put a uniformed armed guard in every school. And I have my questions about what that means to communities of color, what it means in certain neighborhoods, what it means in very young elementary school kids and so forth. What they did not do and talked about but didn't do, they didn't put those licensed mental health professionals in the schools. They failed to do that at the last minute. So we seem to have these great ideas and then we somehow don't carry them out. But think about what Kentucky could be like if we were all talking about ACEs, adverse childhood experiences, if we were all talking about trauma-informed communities, trauma-informed schools, trauma-informed parish support groups, whatever it might be. And let's really do prevention at those levels. Dr. Omar is absolutely right. We need to continue to provide treatment over and over and over again because it takes that many times sometimes for somebody to finally get the light and pursue it. But we need to start our prevention with those babies that are born to addicted moms. Do you know that the best program is in Corbin, Kentucky, Independence House, 74 out of 75 babies born drug-free, and they can't get funding year to year. How does that make any sense? So, we need to be educating. We need to be educating our policymakers because they're operating on wrong information. And the more of us that can communicate with them about what some of the research shows, and you all have great research. You have the website that says findhelpnow.org, which is fabulous. But we need to be educating those policymakers as a prevention as well. Thank you.
Thank you. Thank you, Sheila. All right. So we have questions that I can ask, but we have a big audience out here, and we'd love to hear from you. I know our panel would love to hear from you about your questions. And if you have a question, just press your microphone, and it'll turn red, and then I can call on you.
So I have a question for both Governor Beshear and Dr. Schuster. So while the state is doing a lot, especially with needle exchange and stuff, what can we do more or advocate more in our local communities? Because the needle exchange program law as it exists requires 3 forms of approval: city government, county government, and city board of health. And there's been communities where there's been barriers in trying to get approval from those 3 communities, either due to stigma, lack of knowledge, or budgetary issues. And so while the state can certainly attempt to do a lot, it does require a lot of local community work. And and many of us in this profession maybe don't have a background in working in politics or advocacy, at least at the start. So I was just wondering if you both had any advice on how to work within your local community.
Well, unfortunately, politics is the art of the possible. And things that are possible in some places aren't possible in others, or take longer. The first thing I would say to you is it requires leadership. And it requires leadership from the top. When you get in the political world, too many of your politicians put their own interest ahead of the people's interest. Just get down to it. They're worried about re-election. They like their job. They're somebody. They're important. And they don't want to lose that job. And so, gosh, don't ask me to do anything hard. Don't ask me to do anything controversial. Oh, do we need more revenue? Well, maybe we do, but I can't vote for anything that might look like a tax increase. And so they, for the most part, in our state and anywhere, the politicians answer to the squeaky wheel. The old saying about the squeaky wheel gets the grease. Well, the folks that are yelling the loudest, they get concerned about, and so, but they literally just try to back off from anything too controversial. For us to even get a permissive needle exchange program, as I said earlier, I was amazed that we got that far. But what it requires now to make that better is leadership from the top that steps up and makes the case and continues to make the case. Look, you don't get anything done usually the first time out. When I came in to office, one of the things that Jane and I wanted to do was to raise the dropout age in Kentucky. I mean, you'd been able to drop out of school at age 16 since 1920 in Kentucky. Well, maybe in 1920 that was okay because, you know, you could go work on your dad's farm and make a great living and support a family, or you could work in the hardware store downtown or what have you. But in today's world, are you kidding me? I mean, a high school diploma is just a starting place. You can hardly get a job with that. You've got to get more training. And so we thought, wow, what a no-brainer. And let's just do something that everybody can agree with. It took us 6 years to get that passed. I could get it passed in the House, and the Senate would kill it. I'd get it, you know, and my wife would go testify on it, and they would smile at her, and then they would vote it down, and then she would smile at them, and she would say, I'll be back. And persistence finally paid off, and we got it passed. We actually got it passed in a permissive way. The only way they would pass it was to say, okay, we will allow any school district to raise the dropout age if they want to. And when 55% of the school districts in the state raise it, then it'll become mandatory on everybody. I think they thought that'll never happen. 2 weeks after the law became effective, over 55% of the school districts said that's what we need to do. So we got it done. But as Sheila can tell you, and she's hit her head against the wall over there more times than I can count. But it does take persistence, and it takes leadership. And you've got to basically put a lot of these politicians in a situation where they have to do it for some reason, and you got to force it.
I agree with what the governor has said, but I'm going to go at it from your standpoint. So you're the advocate out there. And advocacy is education with passion. That's all it is. And I can't make you be passionate about any single issue, but you know in your own heart of hearts what you're passionate about. And some of that is informed by your studies. Some of it's informed by the kind of epidemiological information that we have. So if your passion is around substance use disorder, nurture that passion. Don't work alone. Look for unlikely partners to work with you. When we passed the parity bill to require insurers to cover mental health and substance abuse at the same levels as physical health, some of our best partners were the faith community, the Catholic Conference, the Council of Churches, the Council of Jewish Women, and legislators said to me, I'm hearing from my pastor about this. What's this all about? It's a social justice issue. People with mental illness were being discriminated against because they happen to have a brain disease and not cancer. That's literally what happened. So think about who in your community you can partner with. Go to a community that's close to you within the same county or the next county over who has done the needle exchange and talk to them. Who did they work with? Who are the voices that they heard from? I do know that the local boards of health carry a lot of weight in those communities. Get to know every member of your local board of health and think about multiple arguments. If it's only, this is just the right thing to do, which is the way I used to testify back in 1978, you know, well, surely it's the right thing to do. No. What are the other benefits from it? use the Hep A, use the Hep C. I mean, these are the things that you've got to have. You've got to have an arsenal. Also remember that logic and rationality does not always win out. Passion and persistence does. So you want to have multiple arguments, but you also want to be there. You want to be there at every Board of Health meeting. I went to a committee meeting where I didn't know what I was doing, and I sat in the front row every single time they met. And finally, the chairman said to me, "What are you here for?" And I said, "I'm waiting for you to call my bill." Okay, let's hear it. So be a presence. We got Governor Beshear to do the K-CHIP expansion because we had somebody, remember, from Kentucky Voices of Health, sitting in the front row of every town forum he did. And when he asked for open questions, we always had somebody said, what are we going to do to get those kids that are eligible but not enrolled into K-CHIP? And after about the fifth forum, he said, I already know the question, and we're working on the answer. So that's what you want to be. And you can do that. You know, the other thing to remind yourself is that you really can do that. Okay? I believe in you.
Yes, just briefly. Great question. There are currently existing 52 syringe service programs alive and well in the state of Kentucky, and they didn't get there easily, all of them. But let me give you a couple of words of advice, and I would reiterate what Sheila has said. You've got to stir the pot, and you stir the pot by getting in there with data and information. This is what's going on in our community. This is what's going to happen to our community. We've lost these many folks because of a variety of infectious diseases. Build a coalition in the community that understands what needs to be done and can articulate it to the fiscal court, to the judiciary, whomever is going to be making that decision in partnership with your local health department. They can give you the data, they can give you the information and tell you exactly what you need to do. The other thing you need to be ready to do in any given moment is defend what a syringe service program or exchange program is and what it is not. And you ought to be able to do that in your sleep. And so that's crucial to tell them what it can do, what it will do. Use facts like, a high percentage, up to 30 to 50% of those folks who have been involved in syringe service programs will enter into care for their substance use disorder. Data like that is very useful. What it is not a place for enabling drug addiction. And so you've got to be ready to answer that in your sleep.
Just wanted a few words, as I'm not expert like Sheila in doing this, and I had the hardest thing to deal with politicians. But I came to Kentucky with an Arabic name, unknown person, and from day one I wanted to go and start fighting with legislators on various issues. And what I learned during those last 20 years is if you're persistent, if you know what you are talking about, if you put it to the politicians in a way that benefits them, because they don't really give a damn about you, they want to get reelected. That's the truth of the matter. So take some, like I wanted to pass something on kids with disability services. I took a few kids with disabilities to talk to those legislators, and they, at the end of her talk, she couldn't even talk. They stood up in standing ovation and passed the bill the next day. This is, just keep trying. Like this year we passed the expedited partner therapy treatment for STDs. For 20 years, we were only South Carolina and us not doing that. But we kept hammering. This is the 8th time we do it, and finally it passed. So be persistent, know what you're talking about, get some other people involved, and you will get it done.
Thank you.
I was wondering, to anyone who wants to speak about this, how do you see the path going forward as far as reconciling the public health approach, law enforcement, and policy? For example, in some counties, someone could go to a syringe service program, receive clean needles and works and many resources that could help them get clean when they choose to. But in some counties, on their way home, they could get pulled over and charged with possession of materials. How do you deal with that?
I'll take a crack. So, not the right word to use, probably. Forgive me. So one of the things that we are learning as we're trying to get syringe exchange programs, and by the way, let me back up a little bit because I much prefer the term harm reduction, because the platform now around this is a very broad platform. It's not just clean needles and syringes. It is, in fact, substance use disorder recognition referral to therapy. It is preventing infectious diseases, HIV, hepatitis C, endocarditis, you name it, hepatitis A. It is getting folks infected with those illnesses into treatment in a real-time fashion. And it is also providing people information about proper technique, proper use, that sort of thing. When they go to a harm reduction program, they become trusted. The people working there become trusted agents. And so they become a huge resource for those individuals who are in need. Back to your question. In order to make these work, syringe service programs, harm reduction initiatives across the state, you have to have built into the planning the whole police force and law enforcement. You bring them to the table, and they begin to understand what the implications for. So contiguous counties need to talk to contiguous counties. Some of this stuff you can't legislate, right? It's got to be done locally. And I have a theory, you've seen one harm reduction initiative in one county, you've seen one. And it's got to be driven by the local counties, the local districts, and the contiguous counties. So what you've got to do at the same time you're trying to get it started is to build relationships and partners with surrounding counties who are going to be invested in a harm reduction initiative as well, and collaboration. And we're beginning to see that as we're building out many of these syringe service programs. We got a long way to go.
So a lot of time, actually, my experience is police force, fire department personnel, judges are very open if you actually talk to them. So if you are an advocate in a county, don't blame the regular policeman who reads the law, and the law tells him if you find somebody with these materials, you arrest them. But if in every county I worked with, I went to the police and talked to the chief of police, the firefighters, and the juvenile court judge. And instead of arresting the kids when they were drunk or doing something, they would call me and say, let's treat them instead. And the judges stopped sentencing them to juvenile detention because then it gets worse, instead sending to treatment. So you can do that. These people are nice people, the police and the fire people and the judges. They want what is best. But sometimes they don't know what is best. They are told, arrest this person. So work with them, educate them, and I think you will get results.
The other thing I would add, and I think Dr. Omar's done a great job of, don't assume from people's actions that they know what they're doing. Okay? I just heard a little podcast from a judge who said, I came to the bench from being a prosecutor. Nobody taught me about mental health. Nobody prepared me for the fact that we were going to be sentencing so many women. He was in a county in Virginia that never had facilities for women. And now look at how many women are being picked up on drug-related charges. So don't assume, you can't assume that legislators know, what your profession is or what that means or that kind of thing. The other thing is that we do have some really wonderful programs, and we need to lift those up and let people know about them. So how many of you know that in Jeffersontown, Kentucky, which is a large suburb city of Louisville, that their police department has a program called the Angel Program. And if you're picked up on drug charges, you're given an opportunity to come in and have those charges waived if you will go into treatment right then. No court, no nothing. And they want to seize on the moment, which we know is so important. They want to hook you up right then. It's a program that the police there started on their own. They didn't come to me as a mental health person or anybody else, I don't think. But they saw a problem and wanted to do something about it. So get the police to talk to the other police. Go to the school that the judges have every year if you have a program that you want to present, and talk to the judges about, here's a small piece. Start with something small. We call it getting a toenail in the door. instead of a whole foot. Dr. Omar also put a face on the problem. You know, I never go to Frankfurt and testify that I don't have somebody there who's testifying, actually, and I'm just sitting and offering support who is the face of the problem. Because it's a lot harder for a policymaker or a bureaucrat or whoever to just, you know, look at numbers and so forth when they've got a real live person who's sitting there who's been in the middle of this problem. So those are some other ideas for you.
Hi, so I'm within the College of Social Work, so a future social worker, and I'm in the Public Child Welfare Certification Program, which I'll be a future DCBS worker. And so a lot of our cases, I want to say 80-90% of our cases we deal with within the cabinet deal with substance abuse. So how do we work with professionals within the cabinet to better advocate for our clients within legislation, kind of create programs within the cabinet to help better suit our clients, if that kind of makes sense? Yeah.
It's a wonderful question, and I'm so glad that you're here. DCBS, Department for Community-Based Services, is the child welfare part of our government, and it probably has had more attention, I would say, in the last 2 legislative sessions. So you have some real advocates. You have the second in command in the House, Speaker Pro Tem David Meade, and with him Representative Joni Jenkins from Louisville, who's also in leadership. They did House Bill 1 2 years ago that really kind of overhauled the child welfare system. You know, if you've got an idea, whether it's about funding or whether it's about some mandatory training, I'm wondering how many of the DCBS workers actually have had much formalized training in recognizing signs of substance use disorders, of knowing what the impact on young kids may be, what they may have seen or experienced. I would look at some of those issues, but I would talk to some of those, because you've got now some really identified leaders in the House. I think the government, the legislature in general, is more aware of the problem that we've got with these 9,000 kids and so many of them being raised by grandparents. I wonder how much we're doing to support those foster parents and those grandparents. You know, there's a thing called kinship care that was a program started where if I'm a grandmother, which I happen to be a grandmother of 5 wonderful grandchildren, I haven't had to raise them, so I appreciate them all the more, probably. But you've got these grandparents that suddenly have 2 and 3 and 4 and 5 kids, and they're supposed to be getting some financial help from the state, and they had to sue to get the money, and they're still not getting the money. So if we really want to start, you know, talking about supporting people that are going to be a primary influence on these young kids, let's go back to that policy and make sure that policy gets implemented. But I love the question, and I love the passion that you bring to it.
Well, you've raised the big question in the room.
Yeah.
You know, we've been addressing a lot of these questions, and all of these questions come back to that question. Is when you look at Kentucky, and if you want to take Eastern Kentucky as an example, because it's probably more concentrated there, but we've got this problem all over Kentucky, is that we have a significant part of our population that is undereducated, in poor health, unemployed, all of those things that Sheila listed earlier. And for us to ultimately get somewhere, we've got to be able to address all of those things. And we'll never solve it completely, but one step that we have taken is making health care available and accessible and affordable to everybody. Now, that sounds great. It doesn't work, completely, but just if you look at the prevention steps that people have taken in healthcare over the last 2 or 3 years. I saw a study that just came out that said colorectal cancer has dropped 27% because people could finally go and get, since the expansion of Medicaid, because people could go get the test, catch it early. And then, colon cancer is something that they can actually cure if you catch it early. But it's the health care is one big part of this, but the educational attainment that our folks have not reached in many areas in our state is another big issue that we've got to tackle. And, we've got to invest more in public education than we do. We've got some great public educators out there. We've got some great schools out there. But, man, when you look at where we are today and what these children are going to have to do to be able to access the jobs of tomorrow, we got a long way to go. The social services that are needed, because we've got so many kids with just one parent, as Dr. Omar was talking about. It's a huge problem, and there's no way to wave the magic wand and solve it overnight. But I think you have heard that there are things going on in each one of these areas that give us some hope that we can make some significant progress.
So like I said in the very beginning about prevention being the key to this, my first day in opening clinic in Kentucky, I always ask the teens what do they want to be when they grow up. And I had this 13-year-old, and I asked her what does she want to do, and her goal was to get to 18 so I have my own welfare check. This is where we should start, because there are a lot of people in Appalachia who was generations who nobody has ever worked. They're always one generation after the other who are waiting on welfare and things like that. So how do we do it? By, like the governor said, by improving education, investing something in education. I mean, my wife works in the school system, and I know every year they cut more people and add more responsibilities. Healthcare providers need to change the way they address things by, it's not about just looking in ears and mouth. It's about talking to the kids, talking to the parents, educating them about what is important to their kids. And ban Fox News from Kentucky, because basically when you listen to a media that says education is snobism, we need to educate our public that not everything you hear on TV is true, because that's really what they are encouraging them. The goal of some politicians, if you keep people uneducated, they are likely to vote for you. Look at just one more second here. Look what happened in New Zealand last week. I was there 12 hours after the shooting in Christchurch. And the response of the community, that's the electoral community, the prime minister, the entire politicians, even the opposition parties. Everybody stood together because most people were educated, knew that this is not good moving forward. They have to do something about it. They all stood together. They changed their laws in 6 days. Have you ever seen anything like this in the U.S.? You don't. But we can do that. If we all work together, I think we can do something like this.
I love your question, and it is the elephant in the room. And there's a gentleman out there by the name of Sir Michael Marmot. Sir Michael is the gentleman who, in fact, for me, was the first person to explain to me what the social determinants of health were all about. And Sir Michael would tell stories that would make me cry because of what I was hearing about communities in the United Kingdom and the challenges that they were facing, and what recognizing those things did helped that community. Social determinants, where you are born, where you live, where you work, where you die, will determine your health. And so you have to address every part of that where you live piece. And I tell you, it cannot be done simply by just talking about it. It has to be done by putting money into communities that absolutely need it and helping those communities manage the forces out there that will improve the outcomes of what we're talking about. We can flap our gums all day long, but unless we, in fact, empower communities and empower the leaders of those communities to do something, we're not going to see anything happen. And that costs money, which is why we've got to be a Sheila, a Dr. Omar, the Kentucky Medical Association, the Kentucky Pharmacy Association, anybody advocating on behalf of our constituents out there, the people that live in this state and that need the help. Because if we don't do it, we're not going to get anywhere.
Let me point out to you that in the first 3 years of the Medicaid expansion, the utilization of substance use disorders increased by 700%. So there was such a pent-up need, and people knew that, and we reached those people when we did the Medicaid expansion. So the health coverage is part of this. And I just have to say something that is perhaps not politically wise, but I just have to warn you about Governor Bevin's Medicaid waiver and the community engagement piece of that, or the work requirement. It was just struck down for the second time by the federal judge. Our concern has been that at least 100,000 people will lose their Medicaid. That's in the waiver. We think more than that will lose their Medicaid coverage. That's what's happened in Arkansas, not just because of the community engagement, but because of the reporting requirements that have to be done online in a state that doesn't have broadband in, 50% of our communities, and we've argued about that. They ought to be able to do it, by paper and these kinds of things. There's supposed to be protection for people that are, quote, medically frail, which is a horrible term, but it's a federal term. Those people with mental illness and substance use disorders. But the mechanism for getting people designated in that category is far from perfect. And we are so concerned about people finally seeing the light, getting into substance use disorder treatment, and then not having the continuity of care that they need because partly through their treatment, partway through, they lose their Medicaid coverage. So that's something that's out there that we worry about. Let me throw out an idea that's not been talked about, and it, I think, fits the question about Appalachia. Our chambers of commerce, the Kentucky Chamber and the local chambers, what do they always say about what they need in terms of workforce? They need an educated workforce. And I have been singularly unsuccessful in getting them to say, no, we need an educated and a healthy workforce. Yeah. Health is never in there. So what do they say is their biggest problem? They can't find enough workers who can pass the drug screening to get a job or to keep a job. Why don't we work with the business community to put on site 12-step programs, peer support specialists, everything that we know about what keeps people in treatment, and not disqualify from the outset anybody who has drugs in their system or has drugs in their system while they're working, unless obviously they're operating machinery and so forth that could be a danger. Why don't we get the business community that does have some money and does have a real motivation to get people in their workforce and look at pockets, we've got so many of them, where they have a need for workers and there aren't enough workers. Why don't we work with them to see what it would take for those people to really begin to reach out and embrace and support their workers who are dealing with addiction, which is a lifelong problem. This is not something that just goes away. Many of us know people that have been in recovery for, you name the number of years, and they still work at it every day. So this is not something that gets cured, folks, and we need to recognize that and begin to work with our workforce and make sure that the business community is embracing that as well.
So I'll take the liberty, since I've preferred to have our students have front and center, and they've done great questions. You know, if we could talk about one barrier that we could overcome to help us improve our epidemic, what would that barrier be?
So my take always is going to be early intervention, early education. If we start with a kid who's 2-year-old or 3-year-old and talk honestly about these things, not just substance abuse, anything else, it's going to work. The argument I've always been hearing from legislatures here, and I work with 23 different countries. The only place I hear this argument all the time is the US, where if you talk about it, they will do it. If you talk about drugs, they will do drugs. If you talk about sex, they will have sex. If you talk about suicide, they will kill. All the science in the world shows it's exactly the opposite. The more you talk, the more knowledge you have, knowledge is power and improves things. I think that's the first thing we need to break. We need to break this repetitive myth that talking about something makes people do it. People do it because they don't know any better. And if we manage to change that narrative, I think that will be the first step.
Artist, do you have any ideas?
Well, I was absolutely flabbergasted when a couple of years ago I finally learned what the ACEs were about, the adverse childhood events. And I was actually traumatized by the data. And I'm not smart enough to remember the numbers, but the data showing how more than 1 or 2 childhood adverse events, in fact, impacts kids for the rest of their lives. And these are the children that end up doing the drugs, having the mental health problems, get involved in domestic violence. I mean, these are the kids that grow up to be what we're dealing with right now. And I think one of the big barriers is we recognize this, but how, in fact, in our communities, in our healthcare settings, in the legislature, how are we actually making this common knowledge so that we, in fact, can begin when these children are mere tiny children and trying to prevent this? Because I think clearly this holds something over everybody's head for a lifetime.
And I'm going to go back. Actually, it fits in very nicely with what Dr. Omar and Dr. Hovind both have said, and that's to go back to stigma. I think we don't talk about it. I do think that there's that myth out there that if we talk about it, people will do it. It makes us uncomfortable. Within families, it makes you uncomfortable. I remember when my son had to do a family tree, your kids probably had to do that the 5th grade, and I said, well, call your grandparents in St. Louis and ask them those questions. And one of the questions was about alcohol use. And my father was an alcoholic. And that was not the answer he was given by my parents. And so I had to clarify that and talk to my kids who had alcoholism on both sides of their family tree. And it starts with overcoming that discomfort within ourselves, I think, with healthcare providers. You know, I got my doctorate a lot of years ago. I never had a course in substance use disorders. That's how old I am. You know, they still don't do a lot of it. So how much of our medical education, nursing education, even social work and mental health education really looks at substance use disorders and mental illness, because they go hand in hand. You know, 50% of our folks have both, so we really can't separate them. And I think we need to be talking about them. I think they need to be front and center and letting kids know that it really is okay to say, I'm worried about this, I'm down about this, kids are teasing me about this. I mean, all of those kinds of things. So I'm going to go back to stigma eradication. And if you all have an answer to that, it's worth at least $64.
Just one more thing on this topic. It's just illustration of how bad this is. Like, if I see a 16-year-old who is suffering from severe depression, for example, and needs treatment, if I try to prescribe a medicine, the parent always says, why? He doesn't need medicine. Now, if he has a strep throat and I give him antibiotic, nobody objects to that, right? And this is part of the problem. We need to get to a point where we understand disease is a disease. It doesn't matter if it's affecting your brain or your hand or your throat. And if this is the appropriate treatment, then this is the appropriate treatment. Yet people are reluctant to accept treatment because, oh, that means I'm crazy. Or it has nothing to do with being crazy it's just a disease like any others. And that's part of, again, a big barrier towards proper treatment for substance abuse or any mental health issue.
I'm going to jump in if I may, Dean. I used the term earlier, suffering versus pain. And I honestly think I reflect back to when the Joint Commission in 2001 or something made pain the fifth vital sign, because the American College of Oncological Practitioners, whatever you want to call them, were yelling about the fact that there wasn't enough pain medicine out there. And so the Joint Commission made it a fifth sign on patient satisfaction. So as we've talked about, we then went out and, put everybody to sleep with the opioids in order for our patient satisfaction scores to go up. And now in retrospect, looking back at that, and I fully believe this, and I think it blends into the piece around mental health and substance use disorder, that I was treating suffering, I wasn't treating pain. And that suffering, and again, as an infectious disease specialist and an AIDS and HIV expert at the time, I was treating suffering. And so I think one of the challenges we've got in healthcare now is to, in fact, to differentiate and deal with the suffering piece of this, which is the mental health part, the substance use disorder. How do we reconcile ourselves to that in this country? So I think going forward, that has to be on our discussion plate as well.
All right, last question. What is one of the bright spots that you've seen and we can learn from to try to transform our communities?
So again, I'm the guy who's working with teenagers all the time. I'm actually very optimistic. Our younger generation are the ones who will change things. I see a lot of teenagers now who want to be active, who want to be involved, who want to change the narrative around. And you can see it. You can see it in the last 3-4 years, and be it in election results, if you recall the Parkland school shooting in Florida, and the organizations that were supposed to advocate for teens, like the Society for Adolescent Medicine, did not do anything. They issued a statement, or the American Academy of Pediatrics. The kids themselves took it on themselves. They got together. They went to Washington. Yes, it wasn't sustainable because society is not supporting them. But this is how it starts. First step, they sustained it for 8 months, couldn't continue. Next time, they will sustain it for 2 years, for 3 years, and hopefully we'll get the adults to join, because that's the biggest power we have, is our young people. And if we get, our 32nd president, FDR at the time, said we cannot build the future for our youth, but we can build our youth for the future. And that's really where we should look at. This is my brightest spot for looking.
Doesn't have a bright spot. Oh, I do. Okay. I was worried. One bright spot that comes to mind, because it happened in Louisville. 2 legislators from South Louisville that has a huge drug problem said, we're going to have a community forum, and we need to get people in the community to talk about this. And they put it on Facebook, and they got it out through the churches and so forth. And nobody was really sponsoring it. They were really just kind of testing the waters there. Standing room only. So many people, so hungry for information, for the opportunity to talk to a policymaker, to tell their story. And that has continued now for several months. I think that's a bright spot. I think that's the kind of thing that we need to see in these communities. And just seeing you reminded me, you have a resource here at UK, Dr. Ellen Hahn over in nursing, who knows how to get communities to do things like smoke-free ordinances. You should go and talk to her if you want to do your needle exchange or your harm reduction. So that's a bright spot. I also actually think it's a bright spot that although the bill didn't pass, that the legislators at least learned the term trauma-informed care, trauma-informed schools. That we have had presentations by Dr. Brunzel, who is the medical director at the Department for Behavioral Health, in a number of legislative committees around ACEs. So I have to think that we're making some headway in terms of that really just important background education and information. And like Dr. Omar, my practice for 27 years was with kids because I sometimes just presided over what was going to happen with them anyway, and I was there as a witness to it. They are hugely resilient, and our future really is with the kids.
So the final bright spot, I am excited by, enthused by the fact that the whole concept of the harm reduction initiative movement is moving the way it is. And we have groups within the state of Kentucky, the Harm Reduction Coalition, lots of groups now that are being more evident in their local communities. We also now recently have the opportunity here from the University of Kentucky to use something called our state fund, not state money, it's reinvestment funds from the Ryan White program, in which we're now reinvesting into local health departments and communities to build out their harm reduction programs. If they don't have a syringe service program, we figure out how they can do it, and we help them. We're providing funds for this. So now we're going to have the manpower to, in fact, do this, providing education in lots of different venues, providing telehealth around any kind of a topic. So I think there's motion coming out of the university itself in partnership with the Department for Public Health that is going to be able to make this happen. So for me, that is exciting, and it's a really wonderful, bright spot here in the state of Kentucky.
So, panelists, you've done an awesome job. What a great launch to National Public Health Week here at UK. I'd like to just take a moment to thank our speakers. So we have more activities for the week. Check out our website. Tomorrow is Get Yourself Tested and HPV vaccination. So if you're interested, be here tomorrow at 11. Thank you.